anything, we'll just start talking, and Julie will know when to start and when to stop and all that kind of stuff. So I'll just give myself a little bit of space so that she can jump in that front end and stuff. So okay, so we'll start in 3, 2. Hi, welcome to another edition of Stop, Start, Continue. I'm John McMillen with the Medical Memory. We're thrilled to be joined today by Bill Wolf, a longtime pharmacy veteran, who's going to give us some of his thoughts. So before we start into that, Bill, would you give us a background of kind of what your career's been like?
Sure, John, be happy to. So I've been in the healthcare space for a long time, over 35 years. The first third of that, frankly, on the medical side. I'm not a pharmacist. I'm an attorney by background. But the first 12 years or so of my career was as an attorney and then executive with the Blues in Pennsylvania. Starting with what is now Highmark, starting with Pennsylvania Blue Shield, and then got involved in their HMOs in the late 80s and 90s, the Keystone Health Plans. Moved from that, the last 2/3 of the career here, the last 25 years or so, have really been in all aspects of pharmacy. So I joined the Rite Aid Corporation and ran various PBM iterations of PBM that Rite Aid had, starting with a wholly owned subsidiary called Eagle Managed Care. We then acquired PCS Health Systems, which was the largest PBM in the country at that time, which ultimately has been wound up a bunch of times now, where there's still clients at CVS Health that were actually my clients at Eagle Managed Care 25 years ago. Kind of interesting.
Awesome.
All involved in the consolidation, et cetera. Moved from Rite Aid after about 13 years to Catalyst RX, and was president of PBM services there as we merged with SXC to perform Catamaran, which then became part of Optum, which, common theme here throughout in this industry, consolidation, and some of what we're going to talk about today. And then, I've spent some time in other mid-level large PBMs in the consulting space, working with brokers locally. I helped launch RxSense, which is a technology platform in the space, and worked with the team there on single care, discount card, and sort of views towards cost of prescriptions, also in the space. And in between there, I had an opportunity to be on the health plan side, to be the president of Aetna's pharmacy division, running all of pharmacy within the context of an integrated offering. So I like to say I really have a whole 60 view. While at Rite Aid, while I wasn't running PBMs, I was on the other side, contracting with all the PBMs. So I've had the opportunity to have a really 360 view to see all aspects of pharmacy, from retail, mail, specialty, PBM, et cetera, soup to nuts. So very deep domain expertise in kind of all things pharmacy and pharmacy benefits.
Yeah, absolutely. It's amazing career, and I'm glad we've got you here, and kind of timely too, right? We hear a lot of things that are out there between Mark Cuban and CVS, and there's I like to say there's some conversations that are happening. So with the context of your background, which is amazing, and you've seen it, like you said, from 360 degrees, what's something what do we need to be thinking about stopping to make pharmacy practice move forward?
Yeah, I think what needs to stop, in my view, and it's really from a global perspective, is the discussion of pharmacy being just about cost. And because there's an efficiency that gets lost in the mix, and certainly when you look at the patent cliff and where we are with generics at 80+% of all prescriptions filled, and the cost on the non-specialty side really having stabilized over the last 3 to 5 years, frankly. It's really specialty now, 2% of the scripts being 50% of the cost. That's an area to focus on in terms of how is the industry going to address that and manage it, and the engagement there relative to the fact that these things are curative in some instances. There really needs to be a discussion there. But in terms of core pharmacy, I've always had the mantra, look, it's the first used of a benefit year, usually. It's the most used, most accessible, and I believe most efficient. One of the personal stories I like to tell is that my father was a physician. He died 35 years ago at the age of 57 from a massive heart attack while doing grand rounds in the hospital. That was in 1989. Lipitor was launched in 1997. If Lipitor had launched in 1987, Pops might have been around for some of these last 35 years,
Wow.
right?
Yeah. Right.
If you think about it in that context, and then really, sort of think about the efficiency of when someone is compliant and persistent on their meds.
Right.
And you hear it all the time, and it's really was the impetus sort of for MTM and some of the things that have started to touch on where we need to go. And that is that if you keep people on the right meds at the right time, and persistently, you will affect less cost from a global healthcare cost perspective, which, by the way, is still 75 to 80% of all costs are not pharmacy.
Right. Exactly. Right. Yeah.
Numbers been skewing a bit with specialty growing as it is.
Mm-hmm.
But if you can avoid an ER visit by keeping a diabetic compliant on their generic medications, that is a 100-fold saving. So in a broader context, let's move the conversation toward, and we're starting to see that. You referenced it, Mark Cuban, even CVS announcing some things around more transparency relative to their pricing, both on the PBM and the retail side, getting consumerism, into the space relative to the cost and the options is going to help pull this forward in terms of moving the focus away from just cost and rebates and that whole conversation, and really focused on the efficiency and the outcomes that result from the pharmacy benefit and engagement with the pharmacists at the counter.
Those are great points, and keeping folks, you said it, persistently on therapy is key to, cost reduction, which is amazing, but also better outcomes, right? So the patients understand that if they have a better understanding of why they're taking these medications, and the pharmacy is the one that educates them, right? The doctors are most of the time will say, this is why I'm giving it to you, but then you walk out of there, go to the pharmacy, like, what I need this for, right? And then,
well, I think often about my good friend, old friend Doug Long from IQVIA, formerly IMS, that has always told the story of the leaky bucket, and this is where we can kind of morph into START in terms of
perfect. Yep.
Your process start. The START needs to be to finally pull through, and this concept of the pharmacist practicing at the highest level of license.
Yep. Creating
segmentation of the services and things they do so that there are reimbursable clinical engagements that are manageable, and that, from an economic perspective makes sense. But then actually start to we've only made a dent in that leaky bucket all these decades later. Still, many prescriptions go unfilled from the time they're written. Then there's those that are written that do get filled, but then people stop taking them. And it's because there's a lack of engagement. Go back to my Lipitor example. Statins are a great example of I've been on a statin for a decade, so I know, I don't feel any differently one way or the other necessarily. And so I may stop taking it. And there's no engagement. Once I got on that, I just get a maintenance fill now, and nobody ever talks to me about it. Now I see the doc and he checks my cholesterol once a year. Yes. But not all folks necessarily stay up with their medical visits. While they're engaging with the pharmacist, though, there can be touch points, and I've always called it, sort of micro MTM, where it doesn't need to be a 15, 20, 30-minute engagement. There can be a brief conversation of, this is why you're on the statin, this is why it's important you continue to take it. Here's where you are on your compliance level. Those things can have meaningful impact, and we really need to start to pull those things through, not just talk about them. And digital tools and abilities to engage within the context of healthcare providers generally, with pharmacists to physician to nurse practitioner, we can help pull those things through when there's a way to kind of solidify those communications.
Right. Yeah. And that's a great point. I love the phrase micro MTM, right? Because it really is important, and digital tools can make life so much better. Like the medical memory here, hey, you can send short video snippets to patients, just reminding them, here's why you're on it, and this is what we're going to do, this is why you're taking those medications, here's how you take it. Because a lot of times too, in the past, people wouldn't get it filled because they didn't have the money, couldn't find a pharmacy, right? And so many scripts coming out of especially hospital discharges never get filled, right?
Right.
To your point.
Right.
And so a lot of that is just a lack of understanding by the patient, right? And so when they don't get those filled, guess what? They're going back into the hospital most likely, right? For especially if they got COPD or heart failure, or some of the other diagnoses that are out there. They need those tools out there to help them get that. And I like the idea of let's start doing micro MTM. Let's start getting more, kind of a reimbursement for pharmacists and techs to do things.
Yeah, and it's not it's not going to be newfound reimbursement. That's something the industry struggles with. It needs to be a reconfiguration of the economics of all parties involved.
Yeah.
That is really driven by pulling that value from the medical cost. That's where the money is available. And I think, to your point, better engagement. Also, you'll often hear from people, and there's an old quote somebody I worked for once said about when we were talking about looking at patients holistically, and it was really around the concept of Fitbits. And his comment was, show me somebody that religiously uses their Fitbit, and I'll show you somebody that doesn't need a Fitbit. Right.
Right. Exactly. Yeah.
That's the pushback you get. But I think what there can be within the context of these digital tools like medical memory is creating really framework for incenting the consumer to take part in savings that may flow from their compliance, persistency, their view of content that really speaks to how they can better engage their health, why they're getting their medications, having issues with their medications, whether it's cost or they don't feel well on it, adverse reaction, whatever the case might be. The fact that you can continue, to have engagement at the at home virtually, is incredibly efficient, and you can empirically demonstrate what flows from those categories of patients that are engaged within a certain disease state, that do stay compliant, and then don't have the same level of ER visits or readmissions or whatever the case might be.
Right. And we all want to be, if anybody in the healthcare continuum, pharmacists and pharm techs are the ones that most people they're okay seeing, right? It's just and they see them more routinely than typically the other providers in the continuum. So, we've got these great ideas of stopping and starting, and so what's something we're doing right that we should continue to do, or we need to do more of, right, to kind of help push us forward?
It's the pulling through. So there are, the pharmacists have engaged. There's pressure, and there's this push-pull of productivity relative to prescriptions filled and workflow and clinical engagement. And you see that with immunizations, et cetera. But pharmacists have always stepped up. It goes back. I had the opportunity years ago to testify before Congress on the rollout of Medicare Part D. And if you remember, that was a mess for the first 90, 120 days. And it was the pharmacist at the counter, he and she at the counter, that really pulled that through, which is what I testified about. You move on then to Hurricane Katrina, or around the same time, where Short Scripts comes up with a way to do something with interoperability within the framework of prescriptions electronically, prescribed, that allowed for people to get meds when there were when pharmacies were, eliminated by the hurricane.
Right.
Think about H1N1. You think about COVID, etc. Pharmacists are ready, willing, and able to do this, but in order to enable it, a couple of things have to happen and need to continue to happen. There's been, I was lobbying while still at Rite Aid, so this is back to 2011, on the definition of provider, including pharmacists. We're still not there. Need to continue to do that. And then also within that framework, allow for pharmacy techs to take on more within the context of, appropriate training and certification, et cetera, that frees that pharmacist up. And I think you can segment prescriptions. First fills should be treated much differently. Newly diagnosed first fill has an engagement that results in a reimbursement, that includes that engagement and that service provided by the pharmacist, while fill, for routine things, is generally handled by the tech, et cetera. And so those are the things I think we need to, it's not so much continue as it is, well, it's continue in this context, but it's pull through
expand. Yeah.
Yeah. And again, I don't want to make it sound like it's easy. But there does need to be, a consensus and a leveling of the economics that really gets towards the true value of pharmacy as a cog in the machine of helping control global costs, rather than just let's treat pharmacy over here by itself and look at all those costs.
Yep. No, absolutely. And you're right. It's, let's bring the full benefit in addition to the cost, because there's a significant impact. You said, hundredfold, savings with, by getting people on Lipitor or other statins versus going into the hospital for even a night. Right. I mean,
absolutely.
Absolutely, and there we are seeing some progress on that provider status. I think there's a few states out. I think New Mexico is one of them where, because of, and it goes back to, we're a collection of 50 individual states, right? Where depending on what works in New Mexico isn't necessarily going to work in a more population dense location. So we have to kind of focus on getting that status in place in as many places as possible to help our patients, because ultimately patient outcomes are what's going to save the entire system and make people healthier, for sure. So well, great, Bill, I appreciate it. Anything else you want to share with the audience today?
Just to put a pin in it, or to kind of wrap it up, is that there's a the framework is there. We're at an inflection point on all of these things. More so, I think, than we have been at any other time in my career. I've seen a lot of these things. Sure. It's always Back to the Future on some of these things. Where, we talked about that 20 years ago. Like I said, like the leaky bucket we've been talking about for 25 years. Sure. But I think we are at a true inflection point. And it's really, it's around the availability of information on the cost of prescriptions and transparency, the availability of digital tools, the better awareness of consumers, their willingness to engage, to help, use and pull through those tools. And then lastly, there's been a tremendous, whether it's via AI or otherwise, availability of data that will allow for, the proof points on, yes, there is value created. You get a lot of pushback on that. But the fact of the matter is it's common sense, like we've been talking about. Yeah. We know how much an ER visit costs. We know how much, a generic drug costs. I was going to say it's not math, but it is math.
But it's pretty simple math, right? That when we look at that, right, and then to your point, there's so much opportunity and so many great new therapies coming out that if we can kind of bend the cost curve and increase that benefit curve that people perceive with pharmacy, I think we're in a really good space. So.
I agree.
Great. Thank you for joining us, Bill. And to the audience, please be sure to check out the Medical Memory to help bring some of those digital tools into your pharmacy. Thanks. Have a great day.
Thanks, John. You too.
Okay.